25. We want to thank all of you for taking time out of your busy schedules to be here with us this evening. We really do appreciate each and every one of you. My name is Annette, and I am the Director of Outreach for SolidHealth.ai. I did think that I was in retirement for a few years, and then my amazing friend Rashid gave me a call one day and shared his passion and his vision for this amazing new app, and immediately I was hooked. And I'm like, I'm on board, couldn't wait to use it for myself and my family. And with that, what I'd like to do is actually read to you their founder's note and why they built SolidHealth.ai. So they wrote, we started SolidHealth.ai because we lived the uncertainty ourselves. Both of us, Rashik and Raul, have been in the trenches of caring for our parents and close family members. We know what it is like to feel lost in the healthcare maze, to watch information fade from memory, and to only act when a crisis forces our hands. We see a gap every day. We generate so much health data from doctor visits, lab visits, wearables, and even our daily habits. Yet there is no single place to see it all, understand it, and act on it before problems escalate.
Annette, mic forward to you.
SolidHealth.ai was born to change that. Our promise is simple but powerful. Clarity every day, a clear, unified view of your wellness status, guidance you can trust, grounded in science, tailored to you, a true health concierge to help you navigate, decide, and get things done. Connections that matter, keeping your care team in the loop and on your terms. Our mission is to ensure no one ever flies blind about their health care again. Our vision is a world where every person, regardless of age, background, or health status, has the clarity and support to live a longer, healthier, more empowered life. We built SolidHealth.ai for our families. We're here now to build it for yours. Rashik and Raul, co-founders, SolidHealth.ai. So with that, I would now like to introduce Raul, our Chief Product Officer, who will be sharing the product vision.
Thank you so much, Janet, and thank you everybody for joining us today. We like to think that this is a very momentous occasion for us, a start of many such annual events to come, hopefully. But today, as we stand here, I wanted to reflect on the current times, and as they say, this is the era of technology, and we all have witnessed and we've been part of this change that has been growing exponentially with time. Right? So one thing that I was reflecting is, like, when you think about science fiction, what used to take like centuries for some fiction to eventually come true, right? Then started to take decades, then years, and now it looks like within months, something that you were just imagining is coming true. In fact, one thing that I was thinking is, maybe there is nothing called science fiction anymore, it's science germination, right? You are limited by your ideas, your imagination, and whatever you think of. Like, I remember, like, earlier when you used to think about science fiction, you would think about something outlandish, something that you felt like you're just saying for the heck of saying, it's never going to happen. But now that's not true anymore. Like, whenever you say something, many of those things in our lifetimes, we have seen them change. And I know, like me, many of you probably, maybe some of you who are old enough, have been reminiscing of those times. And sometimes it feels like very hard to imagine our own lives that we have lived. Think about that life again. Think about the life without cell phones. Think about the life without internet. Think about the life without, say, GPS when you're sort of driving your car. And I remember the times like early 2000s. I'm not even talking about that far back. Like early 2000s, like me and my wife, we used to work for Ericsson, and we used to go to Sweden very often. And when you are in Europe, you generally take road trips, and just as you would cover states here, you would cover countries here. So you just try to go to different countries. And I remember, like, every time we had to take a road trip, one of the prep work that I used to do was to sit on the map take printouts of various zoom levels of the route, like all kinds of zoom levels. We would have this thick a bundle of papers with us. One of us is driving, the other person has those papers, and we are trying to map what we see to what's on the paper, trying to understand where are we. Are we going in the right track or not? Many times those two things wouldn't match. That was a cue that we need to stop at the gas station and ask for directions. We are lost. And then you would know that, hey, 30 miles ago you missed the turn. Now go back and then turn from there. And now you think that once the GPS came in and we started driving, it was so easy. Now you can go to any place and you have GPS. You don't even need to. Nobody asks for directions anymore. You just ask for, give me the address and I'll reach there. Like those were the times you used to ask, like, well, turn by turn direction if you had to go to visit somebody. And now imagine life these days. It's not even new place. Like even for me to go from my home to my work, which is like my daily commute, I will not do that without GPS because I don't know if there's an accident, the road is closed, if there is too much traffic on one road and I can take an alternate road. So no matter where I'm going, even if I'm going to the same place that I have been going for 20 years, I will still put on GPS and make sure that I feel comfortable that I'm going to reach on time. So the key thing there, when I was reflecting at that experience, is basically earlier I couldn't see what was ahead, neither geographically ahead nor time-wise. I don't know what's going to happen at the next intersection. I don't know if this is the right path or not. So I'm not able to visualize it. And then GPS comes in, it helps me visualize. I can see, like I can zoom, pan, and see what's the traffic like miles away from me. And it can predict what time will I reach there. So there is prediction, there is visualization, and that's basically what we need for our healthcare as well. We need a GPS for our own health, for our own life, and that's the mission that me and Rishik actually are on, and many others that we'll talk about today. So the goal is for us to be able to see our health. GPS probably helps us see what's outside. We'll probably need to see what's inside and understand how are we doing with our health, and can we be guided so that we navigate this journey using the most optimal path, understand where there are going to be roadblocks, and try to avoid those roadblocks sooner than be at that place and then try to figure out how do I take a U-turn from here. So that's the goal for SolidHealth.ai. Our goal is to have clarity of health every single day at any given point in time. How am I doing with respect to my health? Be able to see that. Not only the last time I visited doctor, then they gave me some lab work and I now know that I have a fatty liver, but I don't know if it's still there. Like I'm just hoping against hope that it's all going all well till I end up in the hospital. That's going to happen, right? So that's what we are going to avoid. Avoid hospitalizations, avoid unexpected emergencies, and that thereby help ourselves lead better lives, lead longer lives. You will hear these days a lifespan, or now they call the health span, which is the healthy years of our life, can easily stretch over 100 years. So that's the mission we are on. So at this point in time, I hand it over back to Annette. Thank you.
Thank you, Rahul. All right, so next I will be introducing our CEO and keynote speaker. I just want to say first that I have known Rishik for over a decade, and we worked together for many years. And during that time, I always found him to be, an extremely intelligent, great leader, a caring man, definitely someone you can trust in. And I just, for anyone who knows him, you already know that he's easy to believe in because he's so trustworthy and driven. And if there's any of you who don't really know him yet, I would encourage you to spend time talking with him tonight, because it won't take you very long to realize you do want to attach yourself to this rising star. So with that, Rishik, please.
Hi everyone, thank you for being here. So we are here. Rahul has already explained why we thought we should be here. But who are we doing this for? What are we thinking about as we build this company? I'm going to go through some slides, and this is not rehearsed, so I will probably fumble a few times, so forgive me for that. But let's start with what's our mission statement. The first slide is Care Continuity Concierge. So it's the two parts, care continuity. That's an idea that doesn't exist quite the way we have imagined it. It does not. There are no systems that will allow you to carry your health information from one end to the other end of the spectrum as you want it on your terms. So that's very important because, as Rahul explained, having a GPS about your health is very important because otherwise you don't know where you're going until you have made a wrong turn, and then the cost of turning back can be enormous. So that's the first part of it. The concierge part. One of our advisors, he could not be here today. He's an ex-CTO of Intuit, Bill Erie. He explained to me his experience of healthcare. He's a two-time cancer survivor, and when I was explaining the product to him for the first time, he said, "I've been fortunate to have access to a concierge who can help me navigate the healthcare, and I think that's why I've survived." So, a concierge. Any guesses how much does it cost to have a healthcare concierge? Anybody wants to guess? How much do you have to pay a concierge every year so that they can help you navigate through healthcare? For him, it was $120,000 just for the concierge, right? An average American cannot afford it. Heck, most people here cannot afford it. So we're talking about only the ultra rich people who can afford a concierge, and that's why in your care continuity, concierge is something that you need, you deserve, everybody does. And we are going to look at the next few slides, learn about who are some of the first few people that we want to focus on. It's not an exclusive app or an idea. It is just where we want to start. So if we go to the next slide, we will see Jonathan. And Jonathan is a real person. He was interviewed by the SCAN Foundation. I think I'm missing the attributions over here. This interview was recorded, it says The People Say. It's an organization. You can actually look it up, thepeoplesay.org. And you can look at the interviews of people who suffer every day, not just because they're sick, but also because they don't have access to the best care. And this is the target customer for us, because if we can help them, we believe we can help everybody. Jonathan over here, if we click on that slide one more time, I don't know if you caught this, you will see what's his biggest fear in life. Just press on that. So after everything he's been through life, as some of you would have recognized, he was wearing a veteran's hat. So he is a Vietnam War vet, right? And at this age, he's, I think, approximately 82 or 83. His biggest fear is failure. He's not worried about his health. He's worried about being embarrassed because of his health. So this is where healthcare in this country breaks down, and that's what we need to fix. That's what we are trying to fix. That's where care continuity really matters, and we are going to solve that problem. It might take us a little while, and some of it we will share today, where we are, how far along we are. So let's go and meet a few more people from the same set or repository of people. Next slide, please. This is America today. These are people from different races, from different ethnicities who are struggling with healthcare. Some of them are struggling because they don't have access to the right kind of provider. A right kind of provider does not mean by qualification. Sometimes this lady on the far right, to me, all she needs is a doctor who can speak Cantonese. How big a challenge is that, right? But providing that kind of care to her is not easy in this country. So these are some examples. I don't want to spend too much time. This is the face of America today, and we have to help people who are most vulnerable. And they just tend to be the people who are in the older age groups. And those of you who don't know this already, the senior population is growing at 17% year over year in this country. We are at about 61 million as of 2023 census, and expected to be at about 80 million in about 5 to 6 years from now. That's a large portion of the population in this country who's going to need a lot of care. So we are not only, this is not just philanthropy that we are doing. We are also building a strong business, because we know, like it or not, unfortunately, a lot of people are going to need this kind of care. Next slide, please. What's out there today? How many people over here have iPhones? Just show of hands. Yeah. So you're on the far right side of the slide. You have a medical ID already on your phone, whether you know it or not. And that's like a static application that tells you some information. I don't know if, unless you're in an emergency, you ever even open that app, right? That is not what we believe is access to health data. That's just some information lying in one of the apps, one of many healthcare apps that are on your phone. And if you're not an iPhone user, the best place that you can get health data is on Epic's MyChart. Some of you might have used it, but in a little bit we'll see and compare if what you see on Solid Health AI is that comparable with what's on MyChart. So there's not a lot out there. And what is the problem? Let's go to the next slide. Access to data. I think, and Rahul agrees with me, access to data is probably one of the most central problems in healthcare right now. And physical access looks like the picture on your right, a stack of PDFs or other documents that you can never go through and find the right information on time. Or digital access looks like this. A jumble of charts that even if it has all the vital information, it's hard to make sense of it, right? So what do? Let's go next screen. What we need is building contextual layers of knowledge. There's world knowledge out there, and there is your personal knowledge. And AI today can help you bridge this gap really, really quickly. So what you see in the middle of the screen are layers of contextual knowledge graphs. And once we start superimposing them, which is possible, many of you are technologists yourself, so you know it's feasible. Once you start putting that together, and AI starts unraveling contextually relevant, but still, hard facts that have been proven from which you can retrieve from world knowledge, and tell you how to navigate your health. That's what we believe is going to change the healthcare, the access to data, and some other problems that come along with that. Next slide, please. So at this point, I want to introduce you to somebody whom I have trained under, and today I have the fortune of having him working with me as the Chief Technology Officer. I could not have found a better person. So let's invite Samir to the stage. And he's going to explain to you how are we going to make this happen in a few words.
Thank you, Rishi. Good evening, everyone. I'm Samir Shah. I joined Solid Health as a Chief Technology Officer. I have 30 plus years of experience building very scalable systems, and last 20 years building it using data and AI. What we call AI now used to be a statistical models and optimizations, and it get into machine learning, and now we've gone into LLMs. But if you look at it, it's really based upon two foundational things. One is data, which we talked. There's a lot of data out there on our health. And how do we utilize that using the modern technologies of AI? So what I want to walk through you is how are we thinking about solving and bringing that into Solid Health AI. So how are we innovating that? And these are the three pillars that we are basing our foundations on. What we call Ashwin Duo, which is a platform that we built. The platform that is built upon an agentic AI. I'm sure everyone here has heard about a lot every day because it's in the news. But how do you use the tools and agentic AI to really bring the contextual data about your health and use that and feed an AI to get you personalized information or a contextual information about your health? You can say, oh, I can go and ask ChatGPT today, but it doesn't know about your health. Yeah, it'll give you some information, but it's not going to be personalized. And I think that is the key missing part, and which is a bridge that we want to build here. And how we do that by bringing that contextual engineering. There is a lot of health domain. We want to use that, map your data into that, and then feed into the LLMs to give you contextual answers. From a technology perspective, we want to be cloud agnostic so that some innovation happens at a cost reason, if you want to move to a different cloud provider, or if you go to a different region, it's better to use it. Our application can work. That's from an engineering philosophy that we have adopted. And of course, we want to bring, since it's data, the insights into it. The journey that Rahul and Nishik talked about it is to use that, visualize that, and bring on your face in a simple and manageable way. So that is a platform that we are building it. To complement that, we are building what we call Nova. How now it's giving you that conversational capabilities to ask questions in a simpler way. It will answer you in a way that you understand, based upon your health and your data. So that is a very powerful concept, and we'll talk about how we are surfacing that into your application and into your experience. And then of course everything is about data, and that's where our Health Vectors platform does. It comes in a picture where how we can, it consists of acquiring a data. How do we use that data, creating the right vectors, so that we can use AI in a way that we can learn and access that data. But keeping in mind that your data is yours, making it sure it's secured and it's compliant. So we are bringing all that and making sure that you own your data and ability to share with anyone you want. And we'll talk about how we are doing. But that is the 3 pillars that we are building our application on. Next slide, please. So you heard, there are probably some providers that Rishik showed, and there are many out there. But how do we think and how we differentiate ourselves? So of course there are clinical data and the lab data and other form of data, and there are we can connect to about 50,000 plus providers that we can bring data. Of course your data is not distributed, but it could be any n number of providers that your data might be. We can bring that data on. Of course, probably I'm here, most of you are wearing some kind of wearables which is generating a data. We want to bring that in. Like Rishik mentioned, if you go to your doctor, they only have access to your clinical data. They don't know what is happening between the 2 visits you made. And wearable data, this is something we can bring in, present in a way that it's meaningful for providers to look at that and help them make better decisions. Second thing is, I'm a caregiver, as Rishik and Rahul are for our parents, but also for young. In this country, if your kid is about 18, you don't have access to their data unless they provide you permissions. And even that, it is very difficult. So what we are building here is a way of providing a delegated access to your caregiver with your authorization. So you decide how much data you want to share and with whom you want to share. And once you provide that, it is made easily accessible. And it could be even for your providers. So that's the second pillar we think is very important, and make it easier to have your own data and control your data. Once we have that, and a lot of things, it's okay, now it's an access to my data, what do I do with it? Right? How do I engage? And that's where we're building an engagement model. Where, like Nishik mentioned, hey, you go to your health, how many times you go back and look at it? Because okay, you know the information, what do you do with it? We want to bring that so that you can, on each and every day, you can access that data, but also learn more about it, right? What you were doing yesterday. Maybe you didn't go for a run or a walk you decided to do. We want to nudge you to go and take that extra step, right? So that's kind of how we want to help you and model that and help, to get to a better health. And then, it says customized, I call it personalized pathways, right? We want to create both your personalized by learning your own personal data, but also learning from the cohorts out there. And how do we define with expert providers help and see what we can bring it so that it can help you, like what the concept that we talk. That is a role that we want to play in here to kind of get into whatever your goals are. How do we achieve your health goals? And of course, that cannot happen without data, but also once we have data, we want to bring it up like your credit card score. Right? You look at it, gives you that one instant view, like, oh, my score is 800 or 740. Look, I'm doing well. Right? If I go to 600, so maybe something is not well. I need to take care of it. That's a concept we are bringing, but it just doesn't stop at a high level. Now you can zoom into your. You want to provide your score even at your functional area. Like, hey, how is my heart doing? And you want to score that. So we want to get to that granular level scoring so you can understand your data better at a glance. And then you can have ability to converse more. So that is what our goals from a technology perspective, a platform that we want to build to everything that Rahul and Rishik has imagined and what we want to bring to it. So that is what I wanted to present here. I'm going to be available afterwards if anyone has. So next, I want to kind of show you the video. So how we bring all these things together.
Say no to surprises when it comes to health. Live your life without unexpected pauses. Introducing SolidHealth.ai, your health confidant.
SolidHealth.ai gathers your data from all the hospitals and labs you've visited. It also integrates seamlessly with your devices like your smartwatch, glucometer, blood pressure machine, and more.
Its advanced AI-based analytics expertly analyzes all this data and shows you exactly how your health is doing and guides you on the steps to live better.
Clearly, simply, and confidently. No more guessing. It doesn't just show you what's recommended. It helps you tailor your plan to fit your day. Can't take that walk today?
No problem. Just swap it for a simple stretching routine. Think of SolidHealth.ai as your expert health partner, cheering you on, celebrating your wins,
helping you build lasting habits, and guiding you one step at a time. Its cutting-edge AI technology answers your questions, helps you take action, and never judges.
Just smart, compassionate support. Exactly what you've been looking for. Live longer, live healthier.
And do it on your own terms, with confidence and independence.
To know more, reach out to info@solidhealth.ai.
And that's a real email ID. If you like.
Okay, next we'll be having a panel discussion titled From Intake to Impact, Why Effective Treatment Still Feels Out of Reach. On our panels, I would like to ask Dr. Reyna to please join up here. Dr. Reyna is an internal medicine physician with over 20 years of experience in hospital medicine. He is deeply passionate about telemedicine and emerging healthcare technologies, dedicating much of his career to closing care gaps, particularly in underserved and rural communities. He has worked across diverse health systems where he developed and led innovative telemedicine programs, including telehospitalist services and virtual care models that have expanded access, strengthened clinical workflows, and elevated healthcare deliveries on a national scale. Thank you. And we have Emily Steedman. Please move out of your way here. So Emily is an occupational therapist dedicated to helping people live longer, healthier, and more purposeful lives. Originally from Southern Indiana, she has enjoyed calling the Bay Area home for the past 8 years. Her career has spanned 20 years of rehab leadership in skilled nursing to co-founding a mobile diagnostic swallowing service. She is the founder of a consulting firm specializing in age tech, health, and wellness, helping senior communities integrate technology and functional approaches that support aging well. Beyond her professional work, Emily is deeply committed to global service. She serves on the board of the Haiti Rehabilitation Foundation, helping pioneer university-level physical and occupational therapy education across Haiti. And remoting in, we have Dr. Weathers. Okay. Dr. Weathers is a board-certified internal medicine physician and certified physical executive. He graduated from Morehouse College, Northwestern University Medical School, and completed internal medicine training at Emory University School of Medicine before establishing himself in internal medicine practices in the St. Louis, Missouri area, becoming a top doctor honoree, serving several years running. Dr. Weathers was the medical staff president at SSM St. Mary's Health Center in 2006 and 7. He chaired the Facility Credentials Committee in 2007 to 2011. In 2011, Dr. Weathers began a career in administrative medicine, serving as a medical director with Coventry Healthcare and Aetna, vice president of clinical operations at Blue Cross Blue Shield of Arizona, and the Atrio Health Plans, where he served as chief medical officer. He launched Weathers Consulting LLC in 2023, working with Rebellis Group, CareShield AI, Health Growth Advisory Network, Circle of Health, and others. Dr. Weathers is a strategic advisor to the Managed Care Resource Alliance, MCRA. Dr. Weathers is a member of the American Association for Physician Leadership and is a fellow of the American College of Physicians. He is a past chairman of the board for Gamma Mu Educational Services, GMES, and is a board member of the president of the Northwestern University Medical School Alumni Association. Also remoting in is Dr. EKK. Dr. EKK is an assistant professor of thoracic surgery at the University of Michigan, where he performs high-stakes heart and lung surgery and serves as surgical director of the Michigan Surgical Health and Optimization Program. He developed the SHARP method after recognizing that the decision-making protocols that save lives in the OR could transform leadership in high-consequence business environments. He has consulted with healthcare technology companies, medical device manufacturers, and private equity portfolio companies on clinical strategy, strategic decision-making, and organizational performance. And I'd like to ask Raul, who's moderating, to please take us.
Okay. Dr. Weather, are you able to hear us?
I am, thank you.
Awesome. Dr. EKK, are you able to hear us?
Yep.
Awesome. My mic has some effects, so it feels like I'm singing. But thank you so much. So I'll start with Dr. Vimarsh here. Dr. Vimarsh, like when you have new patients to treat, what's the most frustrating challenge that you wish could be simplified for you?
Thank you, Rahul. Thanks for having me here. So, one of the main things, so my main work is as a hospitalist, and I see new patients almost every day. And one of the main things which is challenging for me is what has happened to the patient before I've seen them. And the initial encounter, almost it seems as if I'm more of a detective than a physician when I'm taking care of those patients. So, and I don't blame the patients. They don't exactly understand what all has happened in the past, what kind of medical history they have. I mean, they can tell me that they have diabetes, high blood pressure, but they don't know exactly all the details of what all has happened in the past. I'll give you a recent example. I had a patient who came in very sick to the hospital. He was having a bleed, and we had to stop all the blood thinners and all the aspirin and antiplatelet medications which he was on. And then when we stabilized him, after that, we were trying to figure out that, okay, now what all medicines should we restart him on? And he said that he had a stent few years back. And when I asked him how many years back, he said like maybe 20 years back. Now 20 years back, the kind of stents we were placing were different as compared to what we are doing right now. So, the kind of decision I had to make medicine-wise would have been different, only to find out that while the patient was there, in like the next 24, 48 hours, we found out that the stent was not 20 years back, it was just 3 years back. And it was the recent drug-eluting stent which he was on. And for those patients, you cannot keep them off any of these aspirin or Plavix or one of those medications. So they have to be restarted on those medications. So, every day we see something where, we have to kind of do a detective work. And patients try to do their best. I mean, one big example I have is every time the patient comes in, they always bring their bottles, empty bottles, which is very helpful to us to figure out what medicines they are on. But they will never think that, oh, there's one medicine which I take weekly or monthly as well as a shot. And nowadays, almost everything is sorry. But so, all the diabetics, they, like not all, but like a lot of them are like Ozempic or something like that. And it does not come to their mind. So we need, we have to like dig deeper into all these things, and only with experience we try to figure out that, okay, what else could have been missed. So this is one big challenge which we have these days.
I understand, because I feel guilty myself. Like every time I go to a doctor and they ask me to fill the medical history, for sure I don't know if I fill the same history every time because I don't remember. Whatever I recall at that point in time. But I've also heard like sometimes people say that doctors should be able to treat patients even if there is zero data available. So what do you think about that?
Sure, yeah. I mean, we are trained that way, and especially with a hospitalist background, that is how kind of my approach is. But we know that if we have more background on what we are dealing with, we know that we can take care of that problem better. So if a patient comes in with some kind of a medication allergy which I am not aware of, and the patient is in a situation, say has some severe sepsis or something, and I have to use an antibiotic, the choice of an antibiotic, if I use one of those antibiotics which I think is the best for him or her, but then only to find out that, the patient is very severely allergic to that antibiotic, I can just make things worse. So yes, we do our best with what we have on our hands, but without medical history, it becomes very difficult for us to deal with things properly.
Yeah, I'll bring Emily in here. So Emily, like you have had so much experience around rehab centers and people coming to you where you are now spending time to fix whatever that is. What are the challenges you see when new patients come in?
Thank you, and also thank you for having me here. It's very exciting to be in this moment with you all. Most of my career treating as an occupational therapist has been in skilled nursing. And when patients come to us, they've been in the hospital they come to us for a short stay. And a lot of times they admit and they've had some level of cognitive impairment. So they can't give us that full history. They can't tell us whatever they can recall may or may not be accurate. And so for us, especially in therapy, we're really looking for the functional history as well as the medical history. So knowing what were you doing at home? What was your home environment like? Do you have steps to enter? Do you have people at home that are going to be helping you out? All of that is really critical for us to develop a plan of care and set goals that then has to get approved for insurance purposes to keep them there. So it's all really important to have that information up front, the functional history and the medical history. When they come to us, we usually get a hospital packet, which could be pretty incomplete. There could be a discharge summary. We may or may not get the therapy notes from the hospital. And most often we are missing some level of diagnostic information. which is important for us to know what transpired in the hospital and where we need to pick up and move on from. So, for example, speech therapists, a lot of times people have swallowing issues in the hospital. They may have had a diagnostic study like a modified barium swallow or a FEES. And if we don't have that information, we may not know exactly what the level of impairment is of the swallow concern, which could, really have downstream effects of what diet they're on and their safety and all kinds of impact to their care right in those moments. So historically, I would say it's incomplete. The information that we do get in skilled nursing. When you look down the continuum into outpatient therapy as well, we often have residents come to us with orders for therapy, but they haven't brought us anything else. We don't have the information from their orthopedic surgeon about the details of their surgery to know what kind of protocols they might be on. So it's always an investigative game for us too. A lot of extra time spent calling other clinics and doctors and even trying to talk to therapists in hospitals. So time wasted, for sure.
That's actually surprising for me because I thought when patients come to Dr. Rana, they are probably coming in fresh and looking for some kind of assistance. But when patients come to rehab centers, they generally refer from some hospital. And I thought like they would have done the detective work and you would just get all the information, but it's surprising that you also don't have that. I actually go to Dr. Ikeke here, and I hope his detective skills are on point because he's going to put people, he's a cardiothoracic surgeon, so he's going to put people on the operation table and cut them open. I hope, Dr. Ikeke, you have good detective skills on that side. What are the challenges that you face?
Yeah, well, I think, I think to that point, the detective skills are obviously a useful component of our work, but no one ever wants to go into an operation that may take 5 to 8 hours blind, right? And I would argue that it doesn't start with just me planning for the operation, but also it starts with me understanding the patient in the beginning. And so a lot of what was said earlier about having had that continuity of care, it's not just the inpatient side, it's the outpatient side. A lot of my patients are not coming from one hospital system. They may be coming from multiple hospital systems. They may be coming from out of state. They may have had a lot of their care in rehab. And so even having a platform where the ecosystems can communicate is essential because someone may have had their care or part of their cancer care in one hospital system, but then they were in rehab for 7 months. So I have no insight on how well they improved to see if they're quote unquote surgically ready, right? So one of the platforms that I talked about in my bio was the M-SHOT, but where we look at surgical readiness. And of all those patients, you don't know just on inpatient notes alone, right? So that's where there is a demand where we can have EHRs communicate and have outpatient clinic assessments communicate and cross-talk because data has become so granular that it's very, very challenging for a provider to kind of put everything or sum everything within 20 minutes of an assessment. If I have to spend half an hour just doing investigative work to decide what's going on, it takes away from my ability to evaluate the patient. So, but all that to say, no one wants to have a surgeon who's going into the operation without knowing what took place the past 6 months, regardless if it's in the EHR or not, right? And so part of our job on the other side, as the system side, is to make sure you have all the information, no matter where it's from, to make a good decision for the patient.
It makes sense. So I remember having a conversation with you, and you said it takes you like 6 to 8 weeks to prepare somebody for a surgery or a procedure. Have there been examples where like you found details that changed what your initial thought was on what process or procedure you were going to take?
Well, I can give you an example. I had one recently. I had a patient of mine who required 2/3 of his lungs to be removed due to a cancer. And what was not in the chart was that he had swallowing difficulties in the past, okay? And that was a big issue because it was actually his daughter-in-law who brought that to my attention immediately after I discussed the operation with the family. And she mentioned that the swallowing issue is not in his inpatient records, but it was assessed in the past on an LCP visit over a year ago, but that was never in this chart, right? And that detail was essential because after we took the breathing tube out of his mouth, if we gave him regular food to eat or drink, he would have aspirated, in which the food and drink goes down the windpipe, and that would have prolonged his length of stay in the hospital. So that sort of detail was essential in how I made decisions. And so because I had that information, I changed our plan on when to give him food and drinks to eat after surgery. So it's minutiae like that makes this kind of platform very important. Because sometimes I have people who don't have a in-law or a spouse or a friend who knows all the details of their care, right? So I'm relying on my team's quick assessment of the records to give me the most accurate information possible to make a decision.
Man, that was scary because I'm just thinking like I probably want to memorize all my details now. So, and I think maybe
or you can use Solid Health AI.
Yeah, I was waiting for that. So I don't have to memorize it. Awesome. So actually, I was like thinking about Dr. Weathers, and I know that you have not been, doing like patient investigations and all for a while. Did you run out of because of all these big detective things that you had to do? How's been, you've looked at care from many angles. Like, what do you think? What's causing this scattering of data all over? And what are your thoughts on this?
I started in medicine back when we were on paper charts. And if we think it's bad now, it was really worse back then. Electronic medical records have made some things better, but clearly they haven't relieved the burden of scattered information and incomplete information. Certainly on the health plan side, when we look at authorizations for care, we're hoping that the provider or the hospital system has provided all of the relevant information, but often we find ourselves having to deny requests for care because there is incomplete information. So if we had a system that would allow a more complete record, it would help speed up the access to care just through that approval process. Let me say also that when we do review appeals for denied care, at least 50% of the time we're overturning those denials because on the appeal we've been given the appropriate information that we can utilize to say yes to the request.
Makes sense. So, and especially because you have both the clinical experience and the payer experience, and I'm actually shifting things from intake to impact now. Like, what do you think, from a payer perspective, is the interest and their effort or their focus when a patient is out from the hospital visit and between the time that they're going to the hospital the next time or to their next checkup? What's the payer's interest in that time when people are in between doctor visits?
That's a great question. Clearly, we want to see care move effortlessly from location to location and that the patient not have a gap in receiving care. So if they've gone from inpatient or post-acute care to home, we want to make sure that the home is prepared for them appropriately, that there are resources there to continue the care that's been provided. We want to make sure that there is follow-up care that's been arranged, that the medications are easily available and accessible to this patient. And a lot of that work has to take place before the person gets sent home. The big gap that we see often is that there's a rush to send someone home or discharge them from a post-acute care setting, and there's been inadequate work on the home side to assure that there's continuity of care.
Yeah, and I would assume that sort of leads to, if they don't get the right care, it ends up being a re-hospitalization, and that's something that payers do not understand.
Exactly. It's terribly expensive.
I understand. So Dr. Ikege, like for you, when you have sort of taken all the effort and gotten the person sort of did all the cuts and the stitches back, what are your sort of, interest in ensuring when you discharge a patient that they are taken care of in your absence, and what kind of things do you generally track post-operation?
Yeah, that's the question. So it depends on the operation, but in general, what I tell patients, the work really starts after the operation, right? Because after I do my huge my point of expertise, the recovery is very much dependent on so after, right? The recovery is dependent on how well conditioned the patient was coming to surgery, with the independent of what I do, their medical history, all that stuff has to be leveraged in how they recover after the operation. Now, let's say they get through the operation and they get a hospital stay, 3 day course, right? That's fantastic, high fives. But now they have to actually survive when they go home, okay? Because if someone passes away in 30 days, that's a failure on me. That's a failure on the system. So it's not so much making sure they get out alive from the hospital and have a decent quality of life. They need to actually make it through with the reasonable recovery even after the operation, right? So the 90-day window is still in a window where we're penalized for readmissions and surgical site infections and so forth and so forth. But not everyone goes home after surgery. Some folks do go to rehab. Some people have to go to special facilities to get stronger. So, and I have certain instructions. I'm very particular about certain cases where they have drains, they have strict diets, they have very strict physical therapy needs. And so those things become less controlled when they're not in the hospital. And so I depend on how we communicate those efforts and those instructions to the teams that take care of the patients outside the hospital, whether it's physical therapy, occupational therapy, speech pathology, PM&R, all these other access to the patient's care. I want to transfer that to them. And sometimes that communication is great, and a lot of times it isn't. And it's not because of incompetence. It's just, when you're dealing with big systems, right, things are lost in the details. And you expect someone who's recovering from a 6-hour operation, who's taking narcotics every 6 hours, to give you all the intel about what's needed for their care and recovery. That's not happening, right? So we need realistic system support. And I believe this is a platform where this is a 4-party one system: the patient, the hospital, the surgeon, provider, and the payers. That's right. And so I think something like this that leverages everyone's expertise, it's a win-win 4 ways. And so because we know that care is not just in one site; it's the multiple sites. But the communication is where we're the weakest right now. So I think this is why this discussion is very important.
Absolutely, and that's something that we are sort of focusing a lot with SolidHealth.ai to ensure that it's not only about knowing what's going on, and it's also about interpreting and understanding what the doctor has told us and what those instructions are that we need to adhere to, and then be able to guide them towards that adherence and making sure that there is the follow-up, that you guys really worked hard to get that person into a certain shape, and then they continue and build on top of that. And we talk a lot about like these therapies after that discharge from the hospital, and we have Emily who has all the expertise in that area. So Emily, like I've always wondered, like you spend like weeks, like it's like 3 to 4 weeks an average span when a person is at such therapist rehab centers, and then you discharge, putting a lot of effort to get them to a certain state. What challenges do you face after they have been discharged from your facility? So they've already gone through the hospitalization, and then they've gone through the rehab therapy. What next? What happens after that? What are the challenges that you actually face?
I love all the shout out to therapy in this conversation. It's really, really encouraging. But no, we always say when we do an evaluation, discharge planning starts on day 1. So we're always thinking about the end through the entire experience. Where are they going next? What are they going to need to be able to do? What kind of resources do they need to have in place to be safe, not land back in the hospital? You mentioned rehospitalizations. I mean, that's been a big point in our world for many years, but there's a lot of reason for it. It's not good for the patient, number one, but also it's costly, and it's a big setback when that happens. And so that's our main goal is to prevent that. Having information in real time is so critical to have a successful discharge. So if we have a patient that does go back to the orthopedic surgeon for an update, there's times where we don't get that report. It might be days before we know what the status is. Did Did their weight bearing status change? How is that preventing us from being able to proceed and move them forward in advance? So time gets wasted when you don't have access to that critical information to keep them moving, especially with the pressures of the health plans and the insurance companies that say, hey, you got to move fast. We have this much time to get these goals met. We can't be wasting time waiting for information. And that just continues downstream. So when we discharge, how are we communicating to the next provider in the continuum? How are they getting all the information of what we've established? The details of some of the things that we do in therapy really can prevent falls, really can prevent rehospitalization. So it's not just one piece of information that you see on one sheet of paper. How can we clearly communicate all the specifics to that next provider? I think there's still a gap in that area within our industry for sure.
And on this panel, like with all you sort of experts, I'm representing the consumers, and we do feel like even if you give us all the instructions, like the moment I step out of the doctor's office, I've forgotten half of it. And then later on, I'm wondering, did that person tell me to do A or B? And then I'm like, I sometimes send messages, and I feel for those doctors who probably getting inundated with so many messages coming in for clarifications that they already gave us. But it's hard, like when you actually do it, then that's when you realize that you don't remember what had to be done. And Dr. Vimash, like these guys are at least like, these are like chronic conditions, and people probably are like super focused to get well because their life has been interrupted. But when people come to hospitals, maybe sometimes it could be like, I have some issue right now, I walk out of the hospital, I feel pretty good. Do you also still feel that there are challenges when a person walks out of the hospital and then meets you like later on, and then what are your challenges on that area?
Yes, definitely. A lot of challenges. I mean, people don't have one thing going on in their life at that time. And I understand, like, the kind of world we live in, it's very hectic, people are busy. After they leave the hospital, health kind of goes down the list because, you know, that one big problem which they had is kind of taken care of now at that time. So, but you know, what we expect the patient to do is kind of follow what we have asked them to do, follow a plan of care. And unfortunately, most patients are not able to follow those things. We do have programs, like for example, CHF patients, we ask them to weigh themselves. We sometimes get automatic, you know, weight readings from them, our nurse calls them, things like that. So we have that for many diagnoses, but it's still not very efficient the way things are working right now. So we basically need something which kind of nudges the patient almost constantly, like a nurse next to them all the time, telling them what is right and what is not right to do.
And like now that we also know a lot about the healthcare system, and we've been, you know, talking to a lot of people that are trying to understand this whole move towards value-based care. And personally, when I sort of started understanding that, I felt like that should have been the case all the time. Like it should be value-based care. Like when I come to a doctor, I expect to be, you know, treated of that thing. But I've also heard very horror stories from a doctor's perspective, like when people go out and they don't follow through. How a doctor doesn't have a magic wand to get them to better, you know, healthy state. So have there been examples, have there been challenges around those areas where, you know, it feels hard to, from a doctor perspective, to go towards value-based care?
See, I'll give you an example. You know, all throughout our lives, our moms have been telling us that drink a lot of water. That is very good for your health. So I'll give you a recent example. So a patient came, and this was like the second or third admission for the patient in the hospital. So I'm like, why are you going in the heart failure exacerbation again and again? She said, I don't know. I take all the medications which have been given to me. Okay, do you restrict your salt? I don't eat salt at all because my doctor has told me, and we don't make anything in salt. Okay, how much water do you restrict? She said, what do you mean restrict? I said, how much water do you drink in a day? I drink a lot of water because that is very good for my health. I said, but that is the real problem. You have to just drink as much as you need. I said, but all our lives we've been told that you should drink a lot of water. So, you know, these are the kind of things where, you know, even if the physician has probably transmitted, but we have those things built in our system, in our life, which we are not able to follow through. the patient is not always able to follow through the care plan, and they end up landing back in the hospital. One reason or the other.
I think that's what Vishik was saying. Like, basically, what we need is that concierge that can help us navigate through after we have sort of visited the doctor, in between those doctor visits. So, Emily, like if you had a magic wand, like that's my last set of questions for all of you. Like you guys can sort of think ahead. Like what's that one thing that you would want from a magic wand?
The list is long, but I will try. Honestly, for me, it's bridging the gap between the health and the wellness components. And we live in an exciting time right now with the wearables, sensors, cameras, all of the digital technology out there. I would want it all in one place. I want the health records and the wellness technologies that we have being built for our own health and well-being all to be integrated in one place where we can see it and use it and have insights into how to best move forward for all of our well-being.
Makes sense. I'm actually imagining a picture of Solid Health value prop, and there's like 0 to 100. I think we've gotten to 40, and just hoping that by the time you guys speak, we would have clearer, validation of what we're trying to do. Dr. Vimarsh, magic wand.
And I'll just add on to this is exactly what we need, and not just that. The patient needs to have it with them. So, even if the patient goes to Florida, which all my patients go in summers, they need to have access to all that data so that the providers who are over there can see what has happened to them, say if they were in California or in the East Coast. So one unified place where all the data is and gets synchronized throughout. So that is what we do.
Yeah, absolutely. Actually, I was talking to a senior once when I was doing the primary research for our app, and this guy had like a trunk full of all the reports from I don't know how many years, because he was on the extreme end of the spectrum where he's like taking care of every single detail, and he had almost a trunk full of documents that he would take with him whenever he visits a new doctor. Dr. Ikeke, like we have had conversations, you have been very passionate about. You also look at things very holistically, not just from a provider perspective, but making sure that the entire healthcare ecosystem itself is more efficient, works better. So if you had a magic wand, Dr. Ikeke, what would you wish for?
That's a bad magic wand. What would I wish for in regards to how this should be applied, or just how healthcare should be done in general?
Whatever you feel like. What if you had a magic wand and you wish for one thing that would make your life better? Like I know that you are very passionate about ensuring that people get the right healthcare. So, what would you want that would help you achieve that?
I know. I mean, ideal world. I'll have all the updated imaging. The time to pre-authorization would be half the time that it is now to get people to the OR, and ideally as well, even after surgery and after their care, people will not be lost in follow-up. Okay, people we the system should be able to know the status of someone's life or death status without someone being out of the system for 5 or 6 years. And unfortunately, that happens a lot. You give someone such complex care, and then they vanish, and then the system has no idea about what happened, and then you find out that they've been in a different place, different healthcare system for a long time. This is a crosstalk. So I think in an ideal scenario, we have a 4-party willing system between payers, the patient, the healthcare system, the individual providers, where there's an ecosystem that leverages AI use to provide a center of excellence, so that people get everything done wherever locally, whichever, and then they still get the care they need.
That makes sense. Pretty long list of things that you want, but I hope some of those gaps we are able to fill.
Yeah, I'm very needy.
Dr. Weathers, you have like the broad picture. You have like the payer angle. You have the clinician angle. Like, what are your thoughts?
I'm thinking about a patient I had back in St. Louis years ago who we were having trouble getting his disease state under control. And finally, a social worker goes out to the house And he very proudly shows her this fishbowl where he'd been pouring all of his prescription bottles into. And when he thought it was time to take medication, he would just reach in and grab a handful of pills and take what he thought was appropriate. We would have had no idea why he was failing therapy if we hadn't gotten someone in the home. So my magic wand is that of all the systems that we create going forward, that we not forget the impact of getting someone into the place where the person lives, so we can see how it is that they experience their life and not just their healthcare.
Makes sense. Makes a lot of sense. I think there are some additional things that maybe Nishik and me are getting from this conversation that we need to think more about. But thank you so much, guys. Thanks a lot for sharing all of your deep insights. You've been experts in your area, and all of your expertise is super useful and helpful for all of us. Thank you so much for all the time that you spent here. Thank you so much.
Thank you. Thanks for the invitation.
Thanks, Dr. AKK. Thanks, Dr. And you guys are welcome to just stay on, watch the rest of the things as well.
So Rahul, you have a video to play.
Yes. So, like what we heard here, there was a lot about having the information, having the most comprehensive information available, having insights available out of that, and then there is a lot about what happens between doctor visits, what happens after the discharge, and what we call as the guided adherence. But what I'm going to show here, as soon as we can get the video up, is a glimpse into one of the experiences that we are building. So some of this experience is actually available now, and you have like those standees behind you. Try to put the QR codes there. You can sign up if you like after this event today. Or you can go to solidhealth.ai, and from there you can sort of install it. What I'm showing in the video is a little more than what is available in the app still, but over the next few weeks, most of these things will start lining up in the app. So I'm just going to show one experience. There are more there. And this is probably the time that we'll introduce, everybody has AI agent these days. Our agent is known as Noah. So he's going to talk about it. He's going to present, actually, I don't need to present anything. So I just outsourced that job to Noah.
Is your Wi-Fi okay?
Wi-Fi is struggling. This is not the next one.
Next one.
Yes.
Hello, I am Noah, spelled K-N-O-A-H, Knowledge Navigation and Orchestration Agent for Health. Today, I am giving you a peek into one experience that I offer. I will show you how I help you have clarity on your health every single day.
Let me show you the solidhealth.ai app. When you access your health profile page on the app, you see your profile at the top. The first thing you see is an overall health score. Look at this as your health net worth. It gives you a good pivot to visualize where you are in your health journey. This is a great at-glance way to put your health in perspective. I don't just throw data at you, I show you your health functions that are at risk or need attention, and health functions that seem to be in good shape. Notice I don't use medical jargon, but everyday terms that everybody understands easily. I also don't leave you on your own to interpret and understand things. I keep popping up at relevant places and help you intuitively understand each element. I play a role of a personal health coach and provide new insights and tips every month. This way you have the required clarity in simple terms. On most days, this information will provide you all clarity you are looking for. If you are looking to dive deeper, with a click, I will help you understand how things have been going over a period of time. You will also see badges you have earned to get a sense of accomplishment from all the efforts you are putting in. You can also check your clinical data, and I will provide you with trends across all hospitals and labs you visited. You can understand each data point and also what it means in common speak. You cannot be second guessing your health and end up with unexpected pauses. Let me help you take control of your health and live healthier, live independently, and live with confidence in your well-being.
And before I go, at risk of being considered a show-off, let me give a peek into my skills as a global citizen.
Puedo hablarte en español.
Je peux vous parler en français.
मैं आपसे हिंदी में बात कर सकता हूँ.
நான் உங்ககிட்ட தமிழ்லயும் பேச முடியும்.
我也会说中文.
You can chat or talk to me in language of your choice, even mixed languages naturally, as you would with a friend. I look forward to talking to you. Try me out. Thank you for listening to me. Visit solidhealth.ai and let's start on our journey. New experiences will keep lighting up regularly. See you on your device soon.
Okay, next I will ask Rashik to come up and give us a glimpse into the future.
Thank you. So I'll wait for the slides to show up. Okay. This is where we're going. This is what we want to do. And we want to, I don't know if you saw the pattern of what the doctors over here explained or all the practitioners over here explained. We are starting by collecting all our data from the EHRs, and then there are hospital visits. So you see your physicians, your specialists, and then you go through therapy and you reach home. And through this, there is a journey that you are taking. And in that process, there is data coming from different sources, different kind of data. And what we want to do is we want to build this comprehensive biomarkers repository, which can accumulate this data, not just every single thing that happened along the way, but also important information extracted as these biomarkers that help with diagnosis, that help with making the best recommendations, and that help with behavioral improvements. So these are the 4 areas that we are interested in. Speech analysis, we already are experimenting with that. We already know there are players out there who build biomarkers or extract biomarkers from speech, and we are talking to a few of them for partnership. In the longer run, we will be able to do that ourselves. Facial analysis, that allows us to check your respiratory rate or your body temperature, and several other biomarkers. There's a lot happening in the lab or the research labs that we want to exploit and bring to our to our repositories. Wearables and sensors, we have heard about them already. And then there is a lot of at-home care emphasis that we are seeing. So home-based lab kits like Function Health. These are some of the startups that are allowing you to do that more and more. There are more names, I won't go through all of them. How do we achieve all of this, right? Next slide, please. We are building 2 important research partnerships, one with CMU. Fortunately, we have Dr. Mayank Goyal. He's on the bridge, and we will be hopefully be able to show a video and then also talk to him. So since he's already here, we might talk to him first and get a few questions answered. So Smash Lab is his lab, and he's going to talk about what the idea of a billion devices is. These are billion medical devices. And then the other lab is from Stanford, Virtual Human Interactions. This is, I think, Walter Greenleaf. He was invited, couldn't make it because he's been traveling quite a lot. So we are talking to him for biosensing. And there is also this, I don't know if you've got this, a consumer journey aspect of how we want to make the care continuity platform really work. And we are talking to this lab to build partnership and then bring those consumer behavioral signals. That was also my area of specialization at Amazon before I started doing this. So these are a couple of things that will allow us to build these biomarkers and leverage them to deliver better care wherever you are as you go. So the next slide, I think, is a short video, but let's see if we can bring Dr. Mayank Goyal on the call. Dr. Goyal, are you here?
Yep, I'm here. But yeah, I think we can play the video first if you want.
Okay, let's play the video then.
And then I'm happy to answer, any questions and talk more.
Perfect.
Hello, everyone. My name is Mayank Goyal. I'm a faculty member at Carnegie Mellon University, or CMU, here in Pittsburgh. And today I'll very briefly give you an overview of some of the research that we have been doing at CMU in my lab called SMASH Lab. And the research agenda that we have, we call it 1 billion medical devices, where we want to use far from perfect machine learning in healthcare. Now, when I talk about these billion devices, I'm not saying we make new devices. Rather, in most cases, we want to use the technology that we already have. For example, it could be our phones, it could be our computers, tablets, smart speakers that we have in our homes, etc., or even smartwatches. So I've built several health sensing systems in the last 10, 15 years, ranging from being able to detect newborn jaundice using phones, lung impairments using similar devices, or diet monitoring using eyeglasses, etc. But what I want to do today is talk about a few of the new works that we are doing that I think many of you will be more interested in learning about, where we are building these smart end-to-end health sensing systems where we first measure the physiology or the behavior of the patient. We share that information with the caregivers, such as nurses and doctors. We explain the information to the caregivers and patients, and then ultimately we help them make the decision. Now, the first project that I'll talk about that gives you an idea about the breadth of work that we are doing here is around children with ADHD. And for these children who have ADHD, the diagnosis for that often relies on subjective parents and teachers' assessment, because the doctors will ask parents and teachers to fill out these surveys, and on the basis of that, the doctor will do the initial sort of screening, and then they have sparse clinical observations where the doctors and other caregivers will see the child in the clinic for some time before they make the initial diagnosis. And because the diagnosis is based on subjectivity and sparse observation, there are a lot of misdiagnoses. So for example, there is this quote from a paper from 2012 where it said that boys who were born in December were 30% more likely to receive a diagnosis of ADHD than boys born in January. And same thing is true for girls as well. Rather, instead of 30%, it is 70%. So for both boys and girls, what is the difference if they are born in December or January? So the main thing is because this study was from Canada, and in 2012, the school cutoff was 31st December. So now what happens is the kids who are born in December are the youngest in the class, versus the kids who are born in January are the oldest. So the child born in December is youngest, is more immature. So there is likely that the teacher would find that child to be a bit more immature, a bit active or hyperactive, does not listen to instructions that well, and all of that biases the series of decisions that people make, and ultimately these children are at a higher likelihood of getting an ADHD diagnosis. So we have been trying to use systems to identify how we can add some objectivity into this process. So I won't go into too much detail, but basically we are collecting data from smartwatches, motion sensors data. So here you can see motion sensor data from 2 children. And this initial period where you see a lot of motion, they were playing. In the next part, they are supposed to be reading. Now you can see that child A, the first child that we see here, is moving around a lot more while they are reading as well. And they had an ADHD diagnosis, or our experts identified them to have ADHD symptoms. So now what happens is you want your watches, the devices that we are able to use on a daily basis, that we are comfortable with our children wearing, being able to detect these kind of things. So you have built machine learning models. Quite cutely, my students came up with the name Samosa for that for this project. And we use this to identify, the system sort of identifies, is the child supposed to be quiet at this time or are they supposed to be active? And when we use this information to just come up with the objective measure of hyperactivity, across all of these measures, we very reliably are able to detect hyperactivity in these children using no input from the parents, nothing from the teachers, just passively collected data from the smartwatches. And now we are using this information to build these decision support systems with pediatricians and psychiatrists that ultimately helps them make the final decision, because we don't want AI to make the decision for you. It wants us to help us we want it to help us make that decision. And all of this work is based on these deployable activity and context recognition systems that we have built for watches and phones. And we have sort of deployed this on with multiple populations for different problems around mental health. For example, with college students at different universities, teenage girls, multiple sclerosis patients, adolescents, breast cancer survivors, etc. And for all of these conditions, some of the things for depression specifically, what we look for is this different modalities in changes in behavior. For example, people who have depression often have trouble sleeping, or some of them sleep too much, depending on the kind of depression they have. Some of them feel a loss of energy, increased fatigue. The physical activities are very different as well, and social interactions are affected. And we have sensors on our phones and watches that can help us identify some of these symptoms. So we combine those together, build a machine learning model, and then can very reliably detect depression, fatigue, sleep quality, a disease burden. In this case, the results are from patients who have multiple sclerosis, so we had a survey around that as well. Another sort of project that I'll very briefly touch upon today is this idea where we are building a context-aware assistant, where the assistant could live on the watch that the person is wearing or on an ambient device. For example, it shows this Google Home graphic right now. And what happens is that as the older adult in a home does a specific task, they can ask the agent questions that, did I miss something? And the agent can adaptively guide the user through the procedure. And there are different modes here. So the agent can guide the person. It can even ask them questions that, what are you doing right now? Because the machine learning is not going to be absolutely perfect all the time. It can observe and remind as well. If it observes that the user forgot a specific step, it can say, don't forget to, for example, it can say, don't forget to wash your hands before touching the wound, in case it is helping another person change a bandage or something for a wound they may have. This example comes from the scenario where we are helping skin cancer patients take better care of their post-surgical wounds. And then it can also answer questions such as, did I miss something? What should I do next? Am I doing this correctly? All these things. So we are building these systems, and we are, as I mentioned earlier, we are working with skin cancer patients who go through more surgery, because right now all they get is a sheet of paper from the doctors. But with recent advances in sensing, machine learning, and AI, we think we can do a much, much better job. So we are trying to use this, the underlying system here is still this model of Samosa that we have built, which rests on a smartwatch. We combine this with ambient sensors to identify different things. So for example, we initially saw how well it works for different tasks. So for example, for active wound care with skin cancer patients, the model was only 40% accurate. That's what we had with just using sensed information. That can sensed information be enough to identify what a person is doing? But turns out it's not enough. You need to have a human AI interaction model that then can ask people questions like, tell me when you do X, what are you doing right now? Are you doing this specific step, etc. So having these dialogues between the user and the agent really helps us improve the accuracy, and that's what we are testing right now. In the interest of time, I won't go through these videos right now, but you get the idea. I'm happy to answer any questions you may have later when we talk. And overall, this agent that we are building, this context-aware situated care assistant, we are testing it out with skin cancer patients and people with dementia in Europe. We are doing these deployments where this agent is deployed in clinics, in people's homes, and they use it, and the people use it in their homes day in, day out, and it is giving them feedback as we speak.
So, if you had any doubts that everything that we want to do is whether it's possible or not, now you know that it's happening in the lab, and very soon it will start happening in at a product level as well. Like I said, Dr. Goyal is here. I'm going to switch over to asking him a couple of questions, but I do want to remind you, a lot of this, it's not only possible, it's life altering for a lot of people who don't have anybody to look after them or provide them that caregiver support. And why is it relevant to us? Dr. Goel's lab is establishing how an ecosystem can be built, and we are not going to be alone, I can assure you. Solid Health AI is going to do its part, but there is going to be more technology coming in this space. All we are trying to do is we are trying to provide a very patient-focused ecosystem or a platform where all of these new devices, new capabilities can be integrated to empower people to look after themselves. So, Dr. Goel, my first question is, on an average, how much does it cost to have this technology in your home today, and how is that cost going to change over a period of time?
Yeah, that's a good question. So overall, it really sort of depends, right? Because in some cases, the examples that I showed today, where you're looking for behavioral markers that we can track using wearables or phones, there the cost is like $50 for a Fitbit, right? And most people already have a phone. So the cost really is $50 if they already don't have a Fitbit. But if you are looking for things where we want to track people's behaviors in their homes and things, then you want an ambient sensor, and that would cost right now, today, the bill of material, if I buy everything on Amazon and I assume that Black Friday sales is not going on, it would be around like $500, right? So, but that cost will keep coming down. And a very important part is that all of these things that we are using are general purpose devices. So we envision that a lot of people will either have these devices already, many of these devices, and the ones they don't have, they can use it beyond the use of just taking care of their health, right? So I think that is a big part there. But but the cost, I think, will keep coming down. Like if you think of just like the compute. So if you think like a lot of algorithms that we run right now run on a Mac Mini. Just 2-3 years ago, the cost of that device was significantly higher than what we get today by Apple, which is one of the like more expensive platforms, right? So I think the costs will keep coming down for compute. But yes, but just to TLDR, to answer your question directly, the cost right now, I would say for an ambient device will be around $500.
Wonderful. And how hard is it to build kind of biomarkers repository that we talked about? I'm glad you were there. You heard, I think, the last part of what all the practitioners want to do with if they had a magical wand, right? And you heard yes. What we want to do by building this repository. How feasible is it to build a solution like this?
So I think it's a very loaded question, right? Because the feasibility is 100%, but the quality is not going to be 100%. So the sensing, the machine learning, everything that we infer is going to be a bit imperfect. So what we need is algorithms and sort of like, user interfaces as well that sort of like convey that imperfection, that uncertainty to the patients, to the caregivers, and also figure out what is the best way to use this information that people are generating. So for example, if a doctor tells someone to, tells a patient that, maintain high levels of physical activity, and if the patient shows their Fitbit data to the doctor, I think today the doctors will listen to, okay, yeah, tell me how many steps you took, or whatever they might want to share. 10 years ago, that was not true. So because as a society, our sort of awareness around these measures has increased, that those measures have started making sense in sort of a medical context as well. So I think similar thing will happen on like across all the other behaviors as well. But I think, again, a lot of these measures will remain a bit imperfect, but we will keep identifying ways to use those imperfect signals as well. But once we do that, I think the feasibility is 100%.
Wonderful. The last question I have for you today is, what kind of role do you think a platform like Solid Health AI can play, for instance, to propagate your research down to, as a product, down to the last person in this country. So there is affordability, there is usability, and there is relevance of a technology like this. Why don't we close this session with your remarks on how relevant you think what we are doing is?
I think in a way you answered your question yourself, right? Like it's like how do you like we can build these things in a lab, in an academic lab, but then how do we make sure that they go to the people, right? That the people use it. So one of the things that happens is a lot of things, almost every single technology that we build in my lab, we deploy it, we test it out in people's homes. We deploy, sometimes the number of users we tested out where there's more than 100, like 500, 600, 1,000 as well. But that's where it stops, right? So to identify which of those ideas sort of make sense to be used by people day in, day out, who are not part of our user study is important. And I think that's the role that Solid Health AI, I believe, will play. And not just the research that comes out of CNU, but also a lot of other places, things that your team will build themselves. And the conversations that you are having with all the practitioners will also help you and me identify what is the right problem to solve.
Wonderful. Thank you. Thank you once again for a wonderful session today. And with this, we are going to move a little bit away from just physiological health and learn a little more about what are some of the needs that we have. I think Emily talked about it's not just health, it's wellness. And what are the components of wellness is what we are going to go into next. So to start, I'm going to invite a friend of mine. He's a musician and he's also very deeply rooted into spirituality himself. He's going to give us a quick overview of what does it mean to be healthy overall today, starting with emotional health. So let me invite Jay Nair, who's going to briefly talk about emotional health.
Thank you. So now that we have the best technology and we have put everything together in Solid Health AI, and what if the user is not in a mood to use it? They just don't feel like opening it. So there is a lot of research that neuroscience reminds that emotional well-being is as important or as vital as the physiological health. And after COVID, there is 25% increase in anxiety and depression worldwide, and half of world population is expected to be experiencing mental health disorder by 2030. World Health Organization says depression will be the number one cause for disability by 2030, and now it is number 3 or 2. So we can have the best technology, the best product, but if the user is not motivated enough to use it, it's not going to work. Right. So how do we change that? Next one, please. So we should, if the app has a component that can capture and make the user or the patient aware of their emotions and moods, capture their tendencies and triggers, and then we can have another module suggest them with how to manage those or how to navigate those emotional landscape using meditations or mindfulness practices or affirmations or any kind of maybe music. So that, and if we have enough data captured from emotions from the user directly, maybe gamify that, and we can suggest, and if the user is using that suggested practice, then we have data from that. Eventually we can have a companion or a mentor to suggest spiritual or even calm abiding or relaxation practices, combining both physiological and the emotional data together. So that is.
So, but you want to talk about the slides over there?
No, I don't want to talk about the other slide.
Yeah, so this is
So that is the concept. That is the. So we have all the technology available now, so why can't Vital AI use that?
Yep, absolutely. Thank you, Jay. So, Jay and I have this friendship that revolves around music. He did mention that music is a part of the solution. And I don't know how many of you noticed we have a station for music over here. We have a band who's going to first talk about a little bit about how important music is to the overall behavioral health. And Farhan over here is going to talk about his personal journey and how that inspired what he's doing right now in the behavioral health space. But before we go over there, I have one thing I forgot, and I want to kind of, because without naming names, I want to inform you there are some investors amongst you here who are probably curious about how well we are doing and, how are we spending, how much money did we spend on setting this up, right? So, in order to give you a quick overview of how we are doing financially, what kind of practices, what kind of culture are we building, I'm fortunate to have with me Harsh, who is our financial advisor, who's helping us keep a very watchful eye on where we spend, how we spend, and how do we maintain our runway, even when we are in this early stage. So Harsh, why don't you come over here and give us a quick overview? And Harsh is also supported by wonderful Supriya. She's over there. She is the one who does our books, and she is amazing. Thank you, Supriya.
Thank you, Rishik. Thank you, Rahul. First of all, I want to thank you both for inviting me on this journey. It's been an incredible journey so far. Just to tell you a little bit about the finances, I think it's all about the approach. Just to tell you a little bit about my background, I'm a CPA. I used to work with Deloitte, EY in my past days, also worked with Intel. So I know the tech side and I also know the accounting side of it. And I do work with quite a few startup companies. And what I'm most impressed is how Rahul and Rishik are running this company for the investors. They have the investors' mindset in mind. Everything is done with lots of responsibility. And I'm very, very pleased with the way they've set up the responsibility around how we're recording, how we're actually setting up our runway, as Rishik mentioned. It's a very thoughtful approach. And we are actually focused on, making sure we look at OPEX, CAPEX, looking at that, making sure it's a reasonable approach. It's hard not to get excited about the idea of marrying AI with medicine and serving this underserved population that obviously needs this type of platform to serve their needs. Huge market, which comes with huge responsibility around the finances because there's a lot of growth, there's a lot of big ramp up in this. So I could say, confidently that, the way we've approached it in terms of putting financial statements together, in terms of how we're putting, with Supriya's help, of course, I see that there is a management mindset where we're trying to look for the future, but we don't want to step too far ahead. We are also very concerned about how we want to reinvest some of the monies that we're making back into the business so we can build a strong enough platform for sustainability in the future. So I think that for the investors, I would feel very confident, that it is a tightly run ship and it is also one that's growing, and I see a huge future with these two amazing visionaries. So with that, I'll go ahead and turn it back to Rishik.
Thanks, Harsh. So you notice how deliberately vague this was, right? You thought we'll give you the numbers? Forget about it. So you got to put in a lot of money to see the numbers that we are making or not making. So let's not continue that conversation anymore. Let's head over to Farhan and Meera. Farhan is going to share his journey, and he's going to also explain how health is not just physiological, emotional, behavioral. It's a lot more than that. And how can we bring health end to end as a part of our journey, as a solution, as a therapeutic device. So handing it back to Farhan.
Just give us a couple of minutes. Just gonna set this up. While we're setting up, I really want to thank Rishik and Rahul for bringing me over and handing me over to give a little presentation. Just see this one?
Check.
Okay, all right. Thank you. Sorry about the delay. I'm Farhan Mohammed. I am an engineer, musician. Been toying with this idea of music as a therapy. I think journey started earlier this year. After my previous job, I started a music company. I'm a what they call prosumer, so I play music quite actively in the community. At the same time, when I had the opportunity, I thought I would start something. And it was a conventional music company that I started, where we do like background scores, gigs, parties, that sort of stuff, big production. Was doing that for some time. A few months back, my dad passed away, so I was in India for the funeral, and I happened to visit some old age homes and talking to them about music and what kind of music therapy they do there, and that kind of caught me into this in this space, and I found it was it was pretty lame, as in some old age homes they had a karaoke system. That's about it. So you get all the patients and they can sing whatever they want. That's kind of the extent of music therapy. So I've been digging into that field a little bit. I notice, it's board certified music therapy therapists who do this kind of stuff out here. So I've been talking to a few, getting some ideas. But what I'm, before I get into that, I'd like also to invite Meera to this concert. She's graceful enough to come and accompany me and show some demonstration of some of the concepts from Indian classical music. She's also a realtor by profession, so she's glad she's around to help me out. So while digging through this, I was talking to Rishik about health and models they use for curating audio, and looking at how a combination of that would be powerful using some of the concepts in music, right? So for thousands of years, music has been used for therapy in terms of singing or singing certain notes and stuff. And over the years, I've been studying a lot about Carnatic music. Carnatic music, by the way, is the classical music in India, from specifically from the South India. In the north, it's called Hindustani, so you can learn something new about the Indian music from today's session, hopefully. So these rags and what are they called, the notes, the intervals, they were designed hundreds of years back for various emotions. And so if you grow up in an Indian household, you'll see that quite a bit. Like morning, there's a morning raga, there's a raga when you have a headache, that sort of stuff. and it's been loosely used. So I've been digging up on some papers and research stuff. There's a lot of stuff out there on the connection between frequencies, auditory frequencies, and how it affects mental health. So I've been studying that, and I'm also looking at models that can actually optimize this kind of stuff. How much information to pre-train these models, and studying some clap-related technology as well. So while this was going on, I was talking to Rushik, and he said, "Hey, why don't you give a demonstration about what are you talking about?" And so I thought, I'll come in. So here we are. So I want to start by saying, showing you some of the Carnatic rags that I mentioned earlier. What rag is basically a scale. Like if in music, if you on a scale of C, you say C, D, E, G. So that combination of notes in sequence is called a rag. So in Carnatic music, they have created those intervals based on how you feel, and it can affect your mood and so on. So we're going to demonstrate a few. So I got Mira here. Let's talk about a particular rag, and we're going to show a few songs written in the rag. And what you'll also notice that the same rag can be used to emote different emotions. A certain rag can be the way it's arranged in the back of the notes. It can be used for like happy, melancholy, whatever emotions you're trying to do. So let's get on with it.
Welcome everyone. Is everyone comfortable? Your head seems to be a little twisted. So, and it's not going to be 2 minutes, it's going to be a while before. So why don't you all shift, take your time? Because music cannot be enjoyed unless you're comfortable. So turn around.
Can you please on the side?
Check. So the first one we are going to do is known as Darbari Kannada. So it's the same it's known in Hindustani as Darbari or Darbari Kannada, and in Tamil, in the south, it's known as Darbari Kannada as well. So the main emotions that most associate with this ragam is spirituality, love, a sense of belonging, love or affection, commitment. So just keep these in mind when we do the notes or related songs too. So this is called the Arohanam, so the ascending and the descending. So it just shows what notes are there, what intervals are there in this rag. Sari ga ma pada ni sa dha ni pa ma pa ga ma ri sa. Satyam Shivam Sundaram, Satyam Shivam Sundaram, Sundaram, Satyam Shivam Sundaram, Satyam Shivam Sundaram, 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 Satyam Shivam Sundaram. जी हमें मंजूर है आपका ये फैसला. बंदा परवर शुक्रिया हंस के अपनी जिंदगी कर लिया शामिल मुझे दिल की धड़कन ठहर जा मिल गई मंजिल मुझे आपकी नजरों ने समझा बहुत प्यार करती है तुमको सनम बहुत प्यार करती है तुमको सनम कसम चाहे ले लो कसम चाहे ले लो खुदा की कसम बहुत प्यार करती है तुमको सनम
हम ढूंढते हैं उनको जो मिल के नहीं मिलते हम ढूंढते हैं उनको जो मिल के नहीं मिल के अब रूठ न जाने क्यों मेहमान मेरे दिल के मेहमाब मेरे दिल के क्या अपनी तमन्ना की क्या सामने आया है दिल ने जिसे पाया था आंखों ने गवाया है टूटे हुए ख्वाबों ने हमको ये सिखाया है दिल ने जिसे पाया था आंखों ने गवाया है टूटे हुए ख्वाबों ने
Looks like the CTO is really in love with this song.
I am really enjoying it.
Okay, good. So this is what we had about Darbari Kannada. So just a shout out. What did you feel? We did 4 songs here. All are contrasting emotions. So what did you feel? Like Tute Hue, what did you feel? Anybody, there's no right or wrong answer. It's very subjective, it's very
There was a
personal.
common rag for all of them, right? The one that you sang at the beginning. Correct.
Yes, it's the same rag, but do you see the emotions? Because Tute Hua was so sad, whereas Satyam Shivan was more spiritual. And Bahut Pyar was, all about romance, right? It was butterflies and stuff. So it's the same rag, but it's used in such a variety of contexts. It's all about the notes and intervals. Okay, so the next one we
Rag
have.
wasn't an emotion. Rag is like a foundational music that any emotion can go with it.
Absolutely.
Correct. Yeah, it's like a scale, like I said. It's a series of notes, series of frequencies, essentially, right? And usually there's something called root. So they'll have a fundamental frequency, and they have the various overtones will make it whatever the timbres, Vienna versus a guitar. But then the intervals, the distance from. I was just talking to somebody earlier. I think it was Jay. They say when you follow a note with a note which is really close, you feel soothing. And if you go further away from that first, so it's relative, right? Relative to the first note, apparently a lot of studies say that it's when you go further away, excited. There's more excitement.
There's more energy.
So in Carnatic households, they say if you have a headache, you listen to this rag, right? So I was very fascinated by that. And it turns out it's the 4th interval of the root. And I was talking to my brother, who's a professor. He's a professor of radiology. So, he studies in fMRI, spinal cord injury, brain stuff, right? So I would talk to him, and he was explaining to me like how intricate that that whole process is. Like it can. There's more to it. There's more variables. So they're looking at oxygen concentration levels. So when you give a fundamental note in the fourth note, it apparently increases the blood concentration levels in that area of the brain. So he actually took this technology and wrote one of the first lie detection algorithms.
Okay.
So if you lie, you're using a certain part of the brain, but while if you lie about your lie, you're using a different part of the brain. So he's able to dial that in. So he does a lot of the stuff. So I talked to him as well, and I noticed that intervals play a huge role. And there's another thing which play a huge role, which I'll talk
Make
to
sure
you
our
about.
wives don't get that technology.
So when we are saying, should we give each of them an oximeter? So the next one we have is called Mishra Pahadi or Pahadi in Hindustani. The closest, there's no exact equivalent in the South Indian Carnatic world. It's known as Mohana. So, and you will be able to associate these, classics. Sari ga pa da sa sa da pa ga ri sa.
Isha? So we're going to try different scales, but what she demonstrated was in the scale of G. But we're going to do a different scale, but it's pretty much the same intervals, right?
जो वादा किया वो निभाना पड़ेगा, जो वादा किया वो निभाना पड़ेगा, जो वादा किया वो निभाना पड़ेगा, रोके ज़माना चाहे रोके खुदाई तुमको आना पड़ेगा, जो वादा किया वो निभाना पड़ेगा, निभाना पड़ेगा। लग जा गले कि फिर हंसी रात हो न हो, शायद फिर इस जन्म में मुलाकात हो न हो, लग जा गले हमको मिली है आज घड़ियां नसीब से, जी भर के देख लीजिए हमको करीब से, फिर आपके नसीब में ये बात हो न हो, शायद फिर इस जन्म मुलाकात हो न हो, लग जा गले अजीब दास्ता है, कहाँ शुरू कहाँ खत्म, ये मंजिलें और की न वो समझ सके न हम, अजीब दास्ता है ये, कहाँ शुरू कहाँ खत्म, ये मंजिलें है कौन सी न वो समझ सके न हम।
We have Jay demonstrating on the same rock, Mohana, right?
शराब हो, जो भी हो तुम खुदा की कसम लाजवाब हो, चौदहवीं का चांद हो, जुल्फे है जैसे कांध पे बादल झुके हुए, आंखें है जैसे में के प्याले भरे हुए, मंजिल है जिसमें प्यार, मस्ती है जिसमें प्यार की तुम वो शराब हो, चौदहवीं का चांद हो.
Thank you. Yeah. So the other thing, so you heard the little bit of demonstrations. It's more like food for thought than like solutions for everything. But I just wanted to take home the message that music is been talked about quite a bit for years and years and years, and music as a therapy is very. We know it, but what we lack really, like I've been reading a bunch of PubMed's publications the last few days just to see the amount of data. We don't have enough data to show that, hey, why would I listen to this piece of rock as opposed to taking 2 Advils, right? For a headache that I have. So that's what we're trying to get. We're trying to get the data. The other crucial thing with music that I'm studying right now is, like, as I'm studying, I'm stumbling across is the fact that a lot of musical emotions that come out when you listen to, when you're embedded, when you're bounded by, when you're given a stimulus of frequencies, is the fact that whatever you listen to during your formative years, that gives you a sense of security when you hear that. So even if it's a piece of music when you're during your formative years, which is not piece of music that you didn't like, when you hear it 40 years later, you tend to go back to that same spot. We all have experienced that. We could even smell in that room like what was happening. It's so powerful. So that's where I was looking at when I talking to Rushik and his personalized kind of therapy, non-pharmacological way of doing it. In this case, it'd be to have, like, if you have user data, to show that you have enough data about the user, the demographic, culture, where they grew up in. So then you can make those kind of recommended music intervention, and that's very powerful. And it's always the case, right? We look at our kids. My daughter, I don't understand what she's listening to these days. And I'm sure my dad didn't understand what I was listening to and trying to do. I was playing rock and roll when I was in my 13, 14 years old. He's like, what is Deep Purple? Like, what is this stuff, right? So that's a huge thing. And I think the more personalized we get, we can actually target based on personalities and where they come from. If we have those kind of data. So just thought I'll add it in there. Before we wrap it up, we'll do one more and then we'll wrap it up. I know it's kind of cold out here and stuff.
So the last one we have is called Bean Plasi or Bean Plus. In South it's known as Abiri. Saga ma pani sa ni da pa ma ga ri sa neno mi pad neno mi badra chai बिजली सी चमके हाय ऐसा मैं बलम कोई बात है किसी को प्यार दे दे किसी का प्यार ले ले इस सारे जमाने में यही प्यारी बात है तन्हा तन्हा यहाँ पे जीना ये कोई बात है कोई साथ नहीं तेरा यहाँ को ये कोई बात है Cinta di ta kita cinta di ta di dum dum ta na dum dum ta na dum dum agapa dum dum ta na di na dum dum agasa ta da dum da na di na ah ta ta da dum da dum ta ki da dum 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 ta na di Tanadirana gama 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 pa maga sani sa Tanadirana gama 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 pa maga sani sa Tanadirana gama 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 pa maga sani sa Come on now, follow my lead now. Come on now, follow my lead. Gama pa maga mama, gama pa mama gama. Gama pa ma gama ma gama pa ma gama sa ma pa ni pa ma gama ma mama pa ma gama sa 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 gama pa sa gama pa I'm in love with your body ooh ah ooh ah ooh ah ooh ah ni ni pa ma ga re sa ni ooh ah ooh ah ooh ah ooh ah pa ni sa sa pa ni sa sa pa ni sa sa ooh ah
Thank you. That's just to show you that music is it's universal. Like you can take the same concepts and apply it to a a Billboard chart, top of the chart song. It's still the same concepts. But yeah, thanks for listening. I hope that was you learned something from the success. Okay, thank you.
Okay, I guess there is a closing remark, but we don't have much of audience left. So I'll just close by saying that dinner is served. So help yourselves, and we'll have a little more music for the night. Yeah, thank you.
Okay.
Thank you.
Thank you so much.